Hello everyone, I'm Rafael Madero and I'm gonna talk to you today about hyperviscosity syndrome and a little bit about leukostasis as part of our hem-onc emergencies curriculum. So starting with the definition, let's start by talking about viscosity. So viscosity of a fluid is the measure of its resistance to flow and based on shear stress. And when we're talking about hyperviscosity syndrome, that is a clinical syndrome that arises secondary to the increase in blood viscosity. Now, I'll go a little bit over the basic components of viscosity within blood, but usually it's the proteins or the whole blood, like we mentioned. So it can be cellular, but it's usually the proteins that end up affecting it. And we call it leukostasis when it's secondary to an increase in the white blood cell count. Why is it important? Well, it is important because it can cause significant end organ damage if untreated. It requires a high degree of suspicion and, a good history and physical. It is manageable and it may even be prognostic in some cases, particularly in leukostasis, where it has been associated with an increased mortality. So these are some of the causes of hyperviscosity. So as you can see, basically, like I mentioned, it's divided between serum and whole blood. Within serum, usually the cause of hyperviscosity is an increase in antibodies. It can be monoclonal usually, but it can be fully clonal as well. So here you have, Waldenstrom's macroglobulinemia, you have myeloma, cryoglobulinemia, and usually when it's secondary to an increase of immunoglobulins, IgM has the highest chance of causing it. It's a little bit bigger. It has the pentameric structure, and it ends up, binding to red blood cells and clustering them together, impeding the blood flow of within the blood vessel, and it can also end up binding to platelets as well, and that can even cause bleeding and other clinical manifestations that we'll go over in a little bit. Now you see within whole blood, you have red blood cells, white blood cells. Polycythemia pathology and management varies slightly. Same with sickle cell disease. We're not gonna really spend time talking about that. But you also have, the leukemias or an increasing white blood cell that can cause leukostasis, like we mentioned. And basically, like this increase in viscosity ends up decreasing or impeding the transit of red blood cells, causes vascular congestion, decreased perfusion, and causes tissue damage subsequently, though the pathology is not fully described for all of these conditions. And these are some of the, clinical manifestations seen with hyperviscosity. And the classic triad includes neurologic abnormalities, visual changes, and bleeding because of the platelet binding that we mentioned earlier. And same neurologic and visual changes because of the vascular congestion in those areas. However, you will not always find the triad, and very typically you'll see mucosal hemorrhage, such as epistaxis and bleeding in different areas. You'll see, like we mentioned, visual disturbances and neurological manifestations include can go up to coma, but you can have seizures and ataxia, and you can even have high output heart failure as well. And in terms of leukostasis, you can also have respiratory symptoms. You can have alveolar congestion as well. And we talked a little bit about the mechanism of leukostasis and hyperviscosity. So I talked a little bit about the immunoglobulin, the pentameric structure in regular hyperviscosity syndrome. With leukostasis, we really have an increase in the total white blood cell count, and mostly, blasts are more susceptible to causing it because they're they have less malleability. It's easier for them to get stuck. It's thought to be secondary to some blast sludging. And then you have other factors as well. So, for example, myeloid cells are larger than lymphoid cells, so you'll have more predisposition with the myeloid leukemias. And of course, when it's acute, when it's blast, because of what I mentioned, that they're less malleable. And there's also other factors that are thought to be involved. You have an potentially increase in adhesion molecules that make them, get stuck in the edge of the vasculature and impedes blood flow that way. And there's a thought that some cytokines released by blasts might also play a key role in hemostasis. Some risk factors associated with an increased risk of leukostasis is, an increased white blood cell count, obviously. Here, like they normally mention, above 100,000. ALL, you usually require slightly more white blood cells, around 200,000. ALL with 11q23 rearrangement or Philadelphia chromosomes have a higher risk, and AML with monocytic AML has been described as well to have a higher risk of leukostasis. And yeah, I forgot to mention, but there's a thought that oxygen consumption by the increase in blast can play some of the mechanism of damage associated with leukostasis and organ dysfunction. And so just wanted to mark the area in the table. The table, I found it in a review article on blood management of hyperviscosity. It's a great article. I recommend you read it. But this is the area of leukostasis, basically. It's a hyperviscosity syndrome, but not every hyperviscosity is leukostasis. And now when we compare the clinical presentation of leukostasis to hyperviscosity syndrome, you'll see that there's a lot of overlap, which makes sense because of what we mentioned. It's kind of similar pathology, vascular congestion due to increased viscosity. There are some differences though in the pathophysiology, like I mentioned. So you will have some slightly different symptoms as well. So CNS involvement, you will have the confusion, the visual defects that we talked about. Respiratory symptoms, like I had mentioned before, it's a little bit more typical with leukostasis, and you can even have severe respiratory distress. And I would say if you have a patient with this and you get blood gas, just remember that you have a significant increase in white blood cell count that will falsely decrease the oxygen levels in your gasometry while you were taking it to the lab. So sometimes it's even better to just go by the pulse ox if possible, if there's good circulation. Fever and DIC, I marked them with an asterisk just because they're a lot more characteristic of leukostasis as opposed to hyperviscosity syndrome, likely because of the cytokine involvement. You also have a lot more hypercoagulability as well, especially if it's secondary to APL. And with hyperleukocytosis, leukostasis, you have to be careful about thrombocytopenia. It's usually underestimated because some white blood cell fragments can be counted as platelets by automated counters. So it has to be, the platelet count has to be counted manually, especially considering that some of these patients will be treated with agents that decrease the platelet count later on. And findings in general for both hyperviscosity syndrome and leukostasis, like we mentioned, it is a clinical diagnosis. And some of the things that you should obtain are, an electrolyte panel, serum viscosity, though you should know, even though if you suspect hyperviscosity syndrome secondary to an increased proteins, you should get it, but you should not delay the treatment if there's a high suspicion. You can just follow up the results after you start the treatment. You can also get coagulation studies, immunoglobulin levels, like we mentioned already, peripheral blood smear, and some of the findings within the labs are pseudohyponatremia, hyperkalemia. Of course, you have a lot of lysis. You can cause spurious hyperkalemia as well by the lysis of cells in the tube while you take it to the lab. Hyperphosphatemia, rouleau formations because of the antibodies like we mentioned. And basically it most commonly presents with CNS or respiratory syndromes. Respiratory syndromes, like I mentioned, it's mostly with leukostasis. And now going over management, so you definitely have to consult HEMONC for hyperviscosity syndrome. Um, you do plasmapheresis until symptoms resolve. It's easier to treat, or patients are more responsive when it's secondary to IgM than other immunoglobulins, and it's not necessarily because of the pentameric structure, but it's because IgM is intravascular, so it's easier to remove. Um, and if plasmapheresis is unavailable, then you can use phlebotomy as well. And just going over some complications of plasma exchange, you can have difficulty with access, you can have hypocalcemia with paresthesia secondary to citrate, hypotension, urticaria as well. And you can even have capillary leak syndrome because removing proteins that quickly from the blood can cause capillary leakage after a decrease in oncotic pressure. And of course, the main thing is the underlying disorder must be addressed. These are just temporizing measures. So meaning like if the patient has multiple myeloma, you have to address the multiple myeloma. If the patient has another reason, another rheumatological condition causing an increase in the antibody count, like you have to treat that. Here you're just treating the emergency with plasmapheresis. You have to look further than that. And of course, avoid blood transfusions since that theoretically increases the viscosity of the blood, like we talked about before. And in terms of leukostasis management, it's slightly different. You still need management by HEMONC, of course. And in general, normally the increase in viscosity is not that marked with an increase in white blood cell counts because there is a decrease in erythrocyte count, even though they're not per individual cell, they don't affect viscosity as much as white blood cells. There is a lot more like a much bigger number of erythrocytes than white blood cells. So the body compensates by decreasing the erythrocyte count. And, it's usually preferable that these patients undergo induction chemotherapy. And if unable to undergo induction and symptomatic, you can do leukapheresis. And if asymptomatic, then you can use hydroxyurea for a lower or a slower, I would say, decrease in the white blood cell count. And well, you need to really keep an eye out for TLS. Obviously, you need to take precautions before cytoreduction with chemotherapy because there's a huge number of white blood cell counts. These patients are very much at risk of tumor lysis syndrome, so you have to be very careful and avoid blood transfusions as well. Same with the theoretical increase in viscosity and counteracting that compensatory mechanism of decreasing red blood cells, like I mentioned. And in terms of leukapheresis, if I mentioned some of the complications, but with APL in particular, you have to be careful about thrombosis secondary to vascular access. And just some take-home points, if clinical symptoms raise suspicion, obtain a good physical exam and history like we talked about. Many times you'll find a condition there that could cause this syndrome. Be wary of high immunoglobulins and or white blood cell blast counts, and act quickly to avoid organ damage and even potentially death. And as a last take-home point, I would also add, know when to escalate, to both HEMONC and the critical care team once you have a patient like this. And these are some of the references that I used to create this presentation. So I hope it was useful for all of you, and feel free to reach out to me if you have any questions.